So, good morning everybody again, dear friends, dear colleagues. I'm very proud to be here together with you. I'm in Romania for the first time in my life, but I'm sure it will not be the last time. We are really enjoying it here, and it's a very nice atmosphere. Of course, the venue and the place you choose from the team is really perfect for a summer conference. And yeah, it's a pleasure for me to be here and to give some of the information and the experience of our institute from Aachen to the rest of the world. As the previous speaker, my colleague and friend Yusuf mentioned already, we started in '91 with laser dentistry. We were getting the first lasers in dentistry delivered out of America at all. In USA they started 89, 90 with the first lasers, and 91 the first machines came to Germany, to Europe, and we got the first machines at this time. And from this time on we started already to do research on lasers in dentistry. We started to conduct programs and courses. The German Society for Laser Dentistry, my colleague and friend Professor Ruprecht, he is president of the German Society as well for many years, was founded in '91. At this time as a study club, but later on it became a real scientific organization. Now we are associated with the highest scientific organization in Germany regarding education in dentistry. And so since this time, for a long time already, we are working with lasers. I'm proud that I'm running the clinical education part. We have at present something like 16 different laser units in our institute. For research, some of them are still prototypes. We're doing evaluation of the right settings and the presets of the machines and so on. But of course, we have the chance to compare all these different machines in the different topics. So if anybody wants to know which laser is the best in which field, then you shouldn't ask anybody who knows only one machine and is working with this, but you have to go to somebody who can evaluate this and is knowing about the different positions and the different settings and capacities of this machine. So that's what we have, and we are very glad and very proud about this. And because of this, maybe, and because we have this physician, you saw the picture of René, my friend. He's from his origin, from his education, he's a physician, and but physics for dentists, it's a very, very tricky thing. I remember when we started with this program, with the Master of Science program, 2004, we did the first program. We conducted the physics part with guys from the Department of Physics at the university. And I was, at this time already, quite involved in laser dentistry and in laser physics and everything. And we were sitting and attending this, of course, as well. And we didn't understand a word, to be honest. No word. And they were so engaged in these things, and after 3 hours of listening, the students from this first group, they came and complained, sorry, but what are they talking about? We have no idea. So then René was there as a newcomer in the team, and he stood up and said, okay, let me explain it to you. So he translated, so that even dentists could understand what his colleagues were talking about. And after this, we started to switch it. Now he wrote a very nice book about this already, like the physical baselines for dentists to understand how light and how lasers are working. And if you see this book and the comparisons inside, then it's very easy to understand what we are talking about. But without these baselines, without this biophysical understanding, it's very difficult to understand what lasers are doing on the tissue, and it's very difficult to understand how to modulate the settings, how to play with the machine in the end to get a perfect result. We saw the previous lecture from our colleague from Israel, how he's playing with the settings, with the parameters, with the machine already. So you can see he has the spirit and the feeling already to use the machine in a proper way. And this is something which we are teaching and which we are talking. And the very good thing, rather, not about you, but very often industry and people from industry are telling you things about the machine, about the capacities of the machine, which are slightly extending the real range of capacity. Yeah, and with this knowledge you will understand what they are talking is correct, is true or not, without discussing even. Yeah? So nobody will tell me about a laser machine, you can do this and this and this, and I know that it's not possible. And that's the big difference. And when you are the Master of Science, or even after the Mastership regarding the wavelengths which I teach there, you know about these details and you don't have to be afraid about this. Well, let's get into the topic of today, the lasers in implantology and periimplantitis. There were a lot of very nice lectures already yesterday and today, so it's not easy for me to show something which hasn't been shown yet. But I mean, I have a lot of passion for laser dentistry. You maybe feel it already. When I'm starting to talk about laser, I'm always very engaged because it's really my heart and my soul, and I can't imagine to have dentistry without laser anymore in my life. Not possible. Yeah? And this is what we try to transfer to our colleagues and students, of course, as well. So, and on the other hand, I'm a German, and with Germans, we love preciseness and details and everything. This is something of our attributes. Sometimes it's very boring, it's annoying even. My wife, she's from Ukraine native, now we are living in Germany, and this is one of her main complaints, that it's sometimes very boring in Germany. But you know, this preciseness is sometimes very helpful, especially in our profession, yeah? Because we are thinking in micrometers sometimes, and if you see what lasers can do, then you're really amazed. So this is the historical part of my city, Aachen. On the upper right, you see our townhouse, and this is the university you saw already. And now I'm proud to say that regarding the number of publications and regarding the amount of scientific work and the patents which we are holding in our department regarding laser development, you can say that we are really the laser dentistry world headquarters in Aachen. Unfortunately, in Aachen, nobody knows about this. This is like always, yeah? The prophet doesn't count in his own country. But all over the world, my colleague, Professor Muelheim, he's very famous because he's by far the most experienced scientist and teacher in laser dentistry, definitely. Okay, this is the topic of today, lasers in implantology and periimplantitis. I will not bother you with physical baselines. I left it in the description, but I erased everything because rather told me show some cases, show pictures, and show how nice things what you can do with laser, because we want to encourage the colleagues to go further into, or maybe to start with this. So we'll talk slightly about some different wavelengths. We talk about indications in implantology, and of course periimplantitis is a little bit part of this. In this field, we have now more than 3,400 listed publications from listed journals with sometimes very high impact, so this is a huge amount of publications. And the majority, like 90%, is with a positive outcome regarding the laser dentist applications and indications. So, but still you will find colleagues who will say, this is only marketing, or insurances, maybe they say, no, it's not scientifically proven, we don't pay for this, and all those things. Yeah? They are just ignoring this development and this process which took place in the last 15, 20 years because it's cheaper or easier. If you think it's only marketing, you don't have to deal with this, because if you start to deal with laser, it means you have to go back to school to learn how it's working, to be really good in doing these things. So it's much easier to say, no, I don't need this. We have the same problem with our scientific organizations. There was a statement, a guideline from the German Society for Periodontology. It was launched last November. And normally in this scientific board, they have to contact the other scientific societies and get approval for this statement. They didn't ask us from the DGR, from the German Laser Society. They just launched it. And laser wasn't mentioned in this with any word. So when it came out, immediately we complained about this, so they had to retrieve it. Now it has to be redone, reworked again. They are very upset about this. But luckily we are in this board, and because of this we can intervene, which will be in the future, I hope, for the benefit of all of us. But there is still a huge need for more research. We need more programs in the field of fundamental, basic research. Yeah? There is research about new wavelengths and about new application forms. I'm very happy I can show you one slide in the presentation where you can see in which direction it might go in the future. Not only printing is something which is coming definitely in the future, but on the other side we have laser wavelengths and laser types which can create very nice, I'm German, and very precise cavities and things like this. So we are optimizing existing systems, yes, of course, with very nice new tools and tips for example, for the iPlus, the undulated 90-degree tip, which is very good for scanning the implant surface and these things. These are improvements for the existing systems, which are making our work better and easier. And what is very important, because nowadays everybody is talking about evidence-based dentistry and all these things, we need more proof from randomized clinical double-blind studies, which are giving proof about the quality outcome of laser dentistry, because there's still a lag. If you compare it with other units, like a turbine or rotating instruments, there's no proof and no evidence as well. They are not discussing about this. But with a new technique like a laser, everybody's looking about this immediately. Where's the proof? Where's the evidence? Yeah. If you combine laser and turbine, from this point of view, you should work with either this or that. Yeah. But everybody's doing. Everybody's working with this, and nobody is thinking even about this, that there's no evidence on a baseline. So this is just the thing you have to mention. It's like when you try to implement such a new technique, it's always more hard work than to work on any existing technology, because it's common and nobody's talking about this. But there's still no universal laser system, even though the industry sometimes tries to implement this into their machines. When I remember the first machine which came from US, it was an NDIAC laser, and there was a catalog with 25 indications. 25 different indications for this machine. 4 or 5 you can do really nice with this. I'm a big fan of the NDIAC still, although it's not that common anymore, because the dyed lasers can do more or less the same. But some special things you can do very nicely with the NDIAC. But there was everything inside. You could cook the coffee, you could make your toast with this machine, and whatever. Yeah, and of course the colleagues, they bought this machine and they started to work with this, and they said, okay, indication number 1, not working, number 2, not working, number 3, okay, number 4, not working. So from these 25, maybe 4 or 5 were left in the end, which were really working. And then there was the rumor in the market, forget about laser, they don't work. That was the typical American marketing, yeah, pushing as many indications aside as possible to make it more affordable for the colleagues. But if it's not working, this is a very stupid thing, because everybody who is aware of the situation and finds out is against it from this moment on. We just focus on these 4, 5, 6 remaining, developed some new techniques, what you can do with this machine as well, because it was the only one available. And now it's different. But you can't do everything with every laser. So that's why, for example, here in the system from Wireless, we have the dyed lasers, the near-infrared lasers, which are very good in the soft tissue, in pigmented tissue, and on the other side we have the hard tissue laser in the mid-infrared for bone, for cavity preparation for hard tissue. So there's a clear difference, and in the courses you will learn why. These are some nice old pictures. I'm not talking about this anymore. But the baseline, this is the combination of today. And with these 2 lasers together, you can cover at least 95% of the indications which are in general treatable with laser, which is very important. Yeah? Some very special things, maybe not, but it's not a question. I mean, nobody is really using a laser for composite hardening. It's possible, but it's stupid. And if you look at the price for a light curing machine and for a laser, then it doesn't make any sense to buy the laser for this purpose. If you have it by accident, okay. So there are some pictures already, the first ones. This was done with the 940 diode. The previous model, not the Epic. I have the Easy Lace still in clinic, and I have the iLace, and I have the Pro, but we did this with the Easy Lace, the previous model, and you see the very nice healing. This is the laser. You see the very nice healing after 4 weeks. It's nearly scar-free, and it was quite big fibroma which we removed. Or here the non-bleeding intervention for the frenectomy. Of course, I'm always coming back to the lecture from my colleague from Israel. I'm always taking out a slight amount of the frenectomy to have a better healing. And this is after 1 week, and there is no recidue because of this. vestibuloplasty, that was at this time something very invasive, can you imagine? And without laser, it was with huge suturing and removing and everything. So for the patient, a totally ugly procedure. And we did this in the past because implants were not that far, and you had to create any prosthetic base which was better for holding the prosthetic things. And after 2 weeks, it's healed already, and you don't need sutures, and you just laser it. It's not bleeding. This is directly after the laser intervention. So even at this time with the CO2 laser, these pictures are from, I don't know, 97, 98, maybe. Even there it was already quite experienced. Today we would use another wavelengths, but okay, it doesn't work. But removal of leukoplakia, this is something which still now mostly will be done with the CO2 laser, because this is the surgical laser with a very nice ablation capacity, and you can shape the tissue with this laser without touching it and remove any malignant structures without any problems. Now this is with an erbium yak to show that even with the erbium yak you can do frenectomy, and of course the same result would be with the erbium chromium or SDG, just with some different parameters. Let's talk about some arguments. There will be another slide about this, because this is sometimes very important, how to convince your patient. I mean, the one thing is to be convinced by yourself why to use the laser. This is the yellow field, and then we have some literature from Romanos and from Kiefhaber about less recidives, good hemostasis, no scar formation, and so on. But what is interesting for the patient? For the patient, it's interesting, we'll do the treatment, and it's a surgical intervention, but you don't need sutures. We don't have to remove it later. It's open healing, and it will be very easy. Less post-operative complications. Granted by Fischer already in '83, he found out that if you do a laser surface with the CO2 laser, it's like a plaster for the tissue, and healing is easier and faster. Nerve sealing, less painful. Nearly no functional disturbance because of no sutures, no difficult intervention, no bleeding, and so on. And safer procedure for high risk. Number 7. I will show some cases about this point later. So, in implantology, we have something like a timetable. Pre-implantologic soft tissue surgery is very nicely performed. This could be something like this. Then the peri-implantologic use of lasers during the implant, the stage 1 procedure. Laser supported, performed second stage, when you reopen, re-entry, or do anything on the way to this place, like soft tissue forming, remove of, we had, yesterday we had a very nice case where the ligaments were disturbing, were quite close to the later implant position, and we don't want to have unattached gingiva close to the implant, so removing these things is a very nice and very easy thing for the patient. I will show some cases about this as well. And but sometimes excision of periimplant gingival hyperplastic periimplantitis and laser-supported implant removal. I will show you a case. We did a nice research on this field as well. We have the big advantage that in our area, the colleagues, they know about the capacities of laser treatment, even if they don't do by themselves, but they know about this. And they know that we are quite experienced in the field of implantology in our team. So when they have any problems like fractured implants, they are sending to our clinic to remove them. And we have research done, I will show later, with very nice outcome. So pre-implantologic, this could be, again, CO2 laser from my colleague, Dr. Schiffer in Berlin. It looks very ugly, directly after lasering. But the advantage is it's no bleeding at all. And when you take a wet cloth and remove the carbonization, then it looks immediately better. This is directly after lasering, after removing the carbonized tissue. And this is a typical process which takes place when you use CO2 laser. But after this, you have a very nice healing and no residues or anything like this. And this is a good baseline for a prosthetic rehabilitation of the patient with a edentulous jaw. But this is something which I really like. This is a very aesthetic picture directly after opening an implant or placing. No, this is after opening an implant. You see the tissue formation process. There's no bleeding. It's a clean process. Very nice, very very aesthetic even. Yeah? My wife doesn't like bloody pictures, but this she can look at. And of course, it was done with my lovely Ferrari, our high class. This was a laser-supported soft tissue stent for transgingival procedure, because this was a patient, 48 years old, with hemorrhagic diathesis, so a strong tendency to bleeding, and he was very afraid about any surgical intervention. Because of this, he was waiting and gaming with implant for more than 12 years and always afraid of the surgical intervention. So when he found out that we can do these things without bleeding and harmless for him, he was very happy about this. This is the initial situation. In general, the bone was very nice, and in height and in diameter in the X-ray. So we did, of course, anesthesia, not without, and there was a very tiny little drill in the beginning, like a point to fix the position of the implant. After this, 2 millimeter burr, and then we placed a guide for a rotating stent. This is the guide in position, and then with the rotating stent, we just mark it, the outline. I just mark it. I don't go deep inside, because then maybe you will damage any vessel, and then you have a problem. I just mark it, and on the next picture you can see quite nicely the margin, and then we are going around with the laser, doing the real cavity. And this is directly after taking out the soft tissue. You see there's more or less no bleeding, even in this case, the patient was very strong bleeding. He showed pictures from other situations. This is the stent which we took out, and then just enlargement to the original diameter. Then we placed the implant inside, the Neos implant, and so this is a patient with hemorrhagic diathesis, implant directly after placing the implant. No bleeding, not at all. And very smooth, very nice margin, everything like it should be. And we placed the healing abutment inside immediately. Of course, it's slightly bigger than the diameter, to have a little pressure on the tissue to prevent suppuration and bleeding after going home. And yeah, this is the X-ray. The patient was referred from another clinic. I can't show you the final picture with tooth on it, because he got lost. We were just responsible for the surgical intervention. But you see, it's a very nice, very clean, very decent work you can do with laser. Very aesthetic even. Not the outcome, but the work itself already. Here we have another patient. He was under Prolia therapy, so he had to take blood thinner. And we performed the internal sinus lift procedure. This was the place where we wanted to fix the implant. You can see I marked the implant position with the laser already. And then after 6 months, the final result. It's the procedure like I showed before with the stem and everything. I'm shortening it a bit, because otherwise there will be no party today in the afternoon. And this is the implant after healing and before impression. This is a view into the future, let's say. Yeah, now there's a new generation of lasers under development and under research, with a very, very, very short pulse length and a very high frequency. These are the ultra short pulse lasers, and they have pulse lengths in the field of nano or femtoseconds. This is 10 highlighted minus 12 or 10 highlighted minus 15 seconds. So this is really short. You don't hear the pulse anymore. If anybody of you work with an erbium laser, erbium yak, or YSTG, you can hear the pulses. It's I don't know, I can turn on the I have one short video I want to show you. I will turn on the noise. You can hear every pulse. And when working, you just hear like a noise, a constant noise, shh, like this. Yeah? But you have, of course, with this high number of pulses you have, and very short pulse lengths, you have a lot of pulses in a very short period of time. And with this you're getting extremely precise margins. This is with a scanned handpiece, so the laser is guiding the beam, and with an ultra short pulse laser we did holes in a bone like an in vitro study, and it's perfectly from the margin. Because this is one of the tricky things when you try to make a preparation on the hard tissue with the laser, you always have these small cavities because it's micro explosion taking out the material. And now suddenly we have a laser with which you can make very precise, very sharp margins, and this is something for preparation of hard tissue, later of teeth or anything like this. And it's very healthy for the structure, because here you can see the cancellous bone inside. And the only problem now, what we are doing research on, is the feedback mechanism during the process to understand how deep am I already, and how much in addition I have to remove. This is something we have to figure out. But the capacity of the machine, and in the end you can do every form. And it's very interesting. I'm an implantologist on the other side, and it's very interesting because with this machine and with this capacity, it's possible later on maybe to make a triangular implant and to place it inside, or something like a blade, because the jaw is very thin, and instead of making big augmentation processes with a lot of possible side effects and risks, you will create a small blade, and your computer is guiding the laser beam to cut into the bone, and at the same time the same data file is going to the metal printer, and during the lasering process the metal printer is making the implant. It's an idea for the future, how it could be.
Yeah, but if the blade fails, how do you get it out?
It comes out by itself.
So,
If the blade fails, it comes out. But we don't want to think about getting them out. And if it has to be removed, I will show you. We have the laser. We saw already yesterday. This is something which you can very nicely do with the I+. And this is something we are training with our students when they come to our institute. They have to laser the sinus window for a sinus lift, and don't damage the Schneiderian membrane below. Of course, we are simulating with an egg, but this is what we are doing. And in real life, it looks like this. Yeah? I prepared this cavity. This cavity I prepared with the erbium and the Schneiderian membrane. You can see behind it's untouched. It's very nice and perfect conditions. This is very nice, very decent, and very precise work. And this is one of the main advantages of the laser. You can work much more precise than with conventional treatment. Yeah? And much more gentle. Implant uncovering, another case, that was a front case. We opened the implants. This was, again, with the erbium chromium. And sometimes, here in this case, I'm using a little bit less water. That's why you have some small carbonization on the margin, but after wiping this, it's gone, and the healing is very nicely, and this is the result after placing the final teeth after 3 weeks, and happy patients. Another case where we have a gain of attached gingiva. This is something which today we are doing in the same setting. You don't have to do a pre-intervention. We just open the implants with the laser. In this case, it was an erbium YAG laser again. And there, on the third implant, you see the attached gingiva is not big enough. We have mucosa directly to the implant. You can see here on the picture already that there's not enough space, and we make something like a small localized vestibuloplasty in this area. Today I'm placing something like a gauze inside with a certain ointment to keep it open, to prevent any residue. And after 1 week, we have a very nice healing. This is another case to show the capacity of the laser to create a very nice emergence profile for the future crown. There was an implant placed after sinus lift procedure, and here on the picture you can see this is not anything which we done with rotating instruments, and we are not creating any flap, because everybody who knows about surgical things knows that only by creating a flap and refixing it without doing anything else, you have already something like around 0.5 millimeter bone loss. Just by creating the flap, opening and closing, 0.5 millimeter bone is gone. And what is in implantology one of the most important things for us? To prevent as much bone as possible. So whenever I have a chance to do any intervention without flaps, That's perfect for me. Yeah. So here you can see how nicely we could create the emergence profile. It's the diameter here is much bigger than close to the implant. Try to do this with the stent. It's not possible because they are cylindrical. And the outcome is really nice. And because the neighbor tooth needed a class 5, it was sensitive. We did in the same session. We did a class 5 cavity here. And this is the final result. You see the class 5 cavity, and this is our implant. Not the one next to it. It was there before already, and later on we changed it because the patient was a bit greedy to do everything at the same time. So this is from profile, from papillas and everything. It couldn't be better. And it's a very small, very decent procedure without big intervention, without harming the patient. Another case where you can see that the attached gingiva is not big enough, and we did the re-entry procedure, and around the implant we enlarged the area. And what we are creating is something like a small scar, but the scar has a much higher amount of fibrosis tissue inside, and because of this it's much stronger, and it's giving us the same effect like attached gingiva. And that's what we are using it. And you can see it's a very nice margin now around the implant, and this is a situation which can be long-term stable. This is the easy lace, the previous model before this beautiful it came to the market. Okay, some arguments for lasers in implantology. Again, scientific arguments, yeah, with, again, Romanos, a colleague from Frankfurt. Now he's in USA. He's a very active in this field, lasers and implantology. And these are arguments for the patients. We have a higher success rate. We have a very strong hemostatic effect, so no bleeding, especially during uncovering. Healing without complications, and in most of the cases when you use the laser, you don't need sutures. This is something the patient loves. And of course, they don't love scalpel. If you say, let's take the laser or let's take the scalpel, then they say, what was it about laser? So these are the arguments. We heard yesterday already, try to think and see the situation through the eyes of your patient, not through the eyes of the dentist. Then it's much easier. Then to convince them to go for this treatment is different. In Germany, it's very important because we have the state insurance. 85% of the Germans are in the state insurance, and they are paying a lot, but they don't pay laser treatment. And as soon as we use the laser, the patient has to pay the treatment by himself. In other countries, it's different. You take the burr and you charge 80 euro for filling, and if you take the laser, maybe you charge 120 or whatever. And so the difference is 40 euro. And then they say, oh no, it's less painful, and I don't like noise from drill, and so I will go for the laser. In Germany, they have 120 or 0. So we need good arguments to convince the patient to go for the laser. Maybe better than in other countries. But therefore, it's very important to see the situation through the eyes of the patient. Do you want bleeding? No. You want scalpel? No. You want sutures which have to be removed later on? Oh no, my God, I don't want. So these are the arguments the patient's understanding. And with these arguments, you can convince the patient to use the laser. And we all here in this room know that definitely the laser treatment will be the better one, and with better outcome, with less risk, with more comfort for the patient, and so on. So we are not selling anything to the patient which he doesn't need. This is the difference. I'm not selling stupid things to the patient. I'm trying to convince him for the better version. And this is something which you have to have in your soul, in your stomach. Then you have no problems to convince the patient. If you're not convinced by yourself, then it's tricky. Periimplantitis, decontamination in the periodontology and implantology is first research was done in 2000 from my colleague Georg Bach. And at this time it was a implant, it doesn't matter, it's not on the market anymore. So there was research done on this, what happened about bacteria and everything, and then later on with the diode laser A10, at this time it was the only one on the market, they tried, and in general you see the bone loss here and the inflammation, and after treatment it looked much better already, but it was an open procedure. Yeah, very important at this time. And this was the beginning of periimplantitis treatment, laser supported. Already 19 years the dentists are working with laser on this field, but still there's no clear concept. And there's no gold standard in treating periimplantitis. And you talk with 10 colleagues and you will find 10 different strategies. Maybe the one is more successful, the other one is less successful. And now we're working on a clear concept like a gold standard in the future for treating periimplantitis. Just the classification again, we have the two clinical phenotypes, the mucositis and the periimplantitis, and the difference in easier words is the periimplant mucositis, inflammation of the soft tissue only. The soft tissue around the implant in most cases is reversible, because if you reduce the inflammation of the soft tissue, then you have a healing. And the clear differentiation to the periimplantitis itself, addition existing and forthgoing bone loss, so the bone is intermittent. So this is the typical sign of a periimplantitis. And what we found out, we are treating maybe 1, 2, 3 cases per week now for a longer time. And as soon as you have a situation like this here, with exposed threads, not the situation the colleague from Israel showed, there was only 2 millimeters of the neck was exposed in the end. After removing everything, you could see this. Before it looked terrible. After this it looked much better. It's a different situation. But as soon as you have exposed threads and these things, and you really want to have a restitutio ad integrum in Latin, so a total restitution of the situation, it's a no-go not to remove the superstructure. It will, in at least 50–60% of the cases, you will fail. And this is a rate which is not acceptable for. So in a case like this, you have to remove the superstructure, and you have to clean everything, and you have to make a augmentation process and a membrane, and to cover everything, and to let it heal in a close way. But what I'm teaching now, when I'm teaching periimplantitis treatment and these things, if you look at this situation, who can tell me if these are implants which were placed right now in this moment, and the colleague found out that there's not enough bone and it needs some augmentation process and some covering, and then he will close it, and after 3 to 6 months he will reopen it, and it will be nice healing because we have no bone formation? Or is this a case of periimplantitis? The superstructure was removed, we have a situation where we see there's some bone loss already, and now we have a challenge because we want to regenerate all these things. Now at the moment, looking at this picture, I'm sure nobody can give any proof if it's this or that version of clinical situation. So the only tremendous difference between the entry stage, when we are placing the implant and we don't have enough bone and we have to make an augmentation, and the re-entry with the periimplantitis case, the only difference is the infected with biofilm covered surface of the implant, the rough implant surface. This is the only difference. Hopefully the implant which was placed was sterile and not from the floor. Then it would be no difference anymore. So implementing that it was a sterile implant which was placed in the proper way in the implant zone, that there's the only difference which we have between this picture and an implant placement with insufficient bone at the implant site is the surface of the implant. And with the erbium YSGG and with the 90-degree tip, or with the straight tips, we have the answer and we have the tool to change this difference and to eliminate this difference. And then it's the same situation like when you place an implant and you don't have enough bone. And you have to undergo, of course, all the same procedure. You wouldn't leave, if this implant was placed right now, you wouldn't leave it like this. Everybody who's making implants, with a situation like this, you would say, okay, we have to place some bone there, I need a membrane, or maybe some augmentation material, doesn't matter, whatever you're using and you're successful with, you should continue even in the periimplantitis treatment. But you wouldn't close it like this and say, maybe there will be some bone in the future. Okay, maybe not. And these are the 50–60% which are not working when you leave the superstructure on top, because you can't make a proper augmentation process with the superstructure in position. It's impossible. So the risk of fail is much higher at this point. This is something you have to explain to the patient in advance, not during the procedure. Oh, we're doing a little cleaning, and then you go home, and then half the way you say, oh, we have to remove the teeth. What? are you crazy? What do you want to tell me? I will go home without teeth? How to do it? So these are things which have to be discussed with the patient in advance. You can see normally on a good X-ray, you can see already a situation like this and what will come. But after cleaning the surface properly with our erbium YSDG, and it is clean, we have research done that around 95 to 98% of the germs and the debris and the biofilm is removed after using the erbium YSDG on the surface in a proper way with the right settings, of course. Then it's no problem to continue like as if you place this implant right now. Make augmentation, make the membrane, maybe fix it with the cover screw, whatever you're doing normally, and then of course close the whole procedure and have a good healing. And after this, there is no sign of periimplantitis anymore, and you will have success. It's very tricky, but it's on the other side, it's so easy. So this is the bleeding of probing as a key parameter to discover periimplantitis. And if you have far-gone lesions, it's accompanied by exudation, like you can see here, and of course bleeding. And some more after removing the superstructure. Yeah? This is definitely a clear sign of periimplantitis. And the raised probing depth is another sign. The bleeding on probing and the probing depth. If you have a raised probing depth, you can be quite sure that it's not only a mucositis, but it will be a periimplantitis with bone involvement. So this is the clear differentiation. And that's why it's a nice idea, which I got from a colleague from Poland. He's doing this for a long time already, and we're doing now for 5-6 years as well. I will show you the chart later on. Raised probing here. This is bony defects. Clinically, intraossary or supraalveolary incidents according to the clinical stage. So there is a clinical stage now already developed. And very important, you will not find, in very few cases, you will find pain in combination with periimplantitis. So the patient doesn't realize anything. And this is the big tricky thing, they are not coming. Maybe it's bleeding, maybe they have sometimes an ugly taste in the mouth, but it's not painful, so they're not coming to clinic to examine the situation. And when they are coming, it's quite late already. Yeah? Radiologic proof, this was the situation, blades. Like, but look at the blade in the fourth quadrant. This is still stable, the others came out, all of them. It was not possible to keep it. So the one thing is probing. An initial probing directly after placing the prosthetic restoration and chart it, keep it. And the second thing is to make a radiographic reference directly after inserting the superstructure to evaluate the further progress. This was directly after placing the superstructure on the implant. We did a charting, and we have a reference line now. And we are doing the probing now. You can see here on this graph. We call it the peri-implant monitoring. The baseline is the placement of the prosthetic superstructure. We are doing a probing. It's not the bleeding on probing, it's more the pocket depth. And we do an X-ray diagnostic. And during recall, if we would find out that we have a raise in the probing depth, we are checking with X-ray, and then we can compare. And we can compare. And we know already immediately, this is a situation which changed, or this is a situation which is now maybe anyhow a little bit inflamed, but there's no bone loss, it's not a periimplantitis, it's maybe only a mucositis. To differentiate this, these very easy things can help a lot in the future. Yeah? And I'm giving this information to my dental hygienist. She's charting this, and when the patient is coming for recall, she's always doing the probing and checking, and if necessary, we are doing an X-ray and check the situation again. And like this, we could eliminate and reduce the peri-implant cases in our clinic from our patients around 50%, which is very nice. Very nice result. But of course we have peri-implantitis cases as well. 50% or maybe more of peri-implantitis is in the hand of the patient. If they don't take care about their implants, if they don't come for dental hygiene, and if they don't do proper hygiene at home, no way to keep it clean and to keep it healthy. So it's not about your implant or the implant from somebody else which you have to treat. It's the implant of this patient which became ill. And I'm not responsible for this. It's in the responsibility of the patient. He's taking it home and it's his implant now. So we have to get free of this damage of your reputation or anything when suddenly there's a periimplantitis case in your clinic. This is another sentence from Professor Becker from Düsseldorf. He's together with colleague Schwarz working in the field of periimplantitis for a long time already. Definitely untreated periimplantitis will result in an implant failure. But on the other hand, if it's not too late, you have a good chance to treat it. This is the which I'm showing to you to show how nicely it's without tone. You know the think about it, but you can see, especially at the tip of the implant, you will see a very nice soft tissue granulation, which is very hard to remove on the rough surface. And with laser, it's so easy, and you can clean it very nicely and perfectly. And periimplantitis without YSTG is not possible for me anymore. There's no go. Of course, here in this case, the backside of the implant was fully intrabony, and we had only exposed lingual side, so it's very easy. You don't need the ambulated tip. It's easy to do with the bare fiber tip. But if you have intrabony defects, then the rectangular handpiece is very useful. A tip, sorry. And it's very nice to clean. And the implant is perfectly clean. But in an advanced case like this, when we have more than 4 millimeter of bone loss, now the new strategy is not to do the cleaning process and the augmentation process in one step anymore, because there we had certain cases of failure. Now we are stepping to a new procedure when we have more than 4 millimeter bone loss around the implant. We're doing the first entry like this with proper cleaning, hygiene, removing all granulation tissue, refreshing the bone in the surrounding, and then we close it. And then after restitution, and when we find out that there's no inflammative process anymore, then the second step is the re-augmentation. This is after 4 weeks, and you see around the implants, very nice, no inflammation. It was very reddish, it was swollen and everything, because you see the patient is using any telescopic prosthetic work on top, and this is supporting, of course, the development of periimplantitis strongly. We changed to a fixed restoration in her case already, and but the healing after 4 weeks is very, very nice, although that was such a tremendous defect. We launched a book. The second edition is on the way, and but the general statement in this chapter of implantology and oral surgery is that they are suitable tools, according to all the literature which we reviewed, a suitable tool. And here you can see how nicely you can work with the laser. You see even the connective tissue fibers here going out when you use the laser with not too much water spray. And this is the result, and this is directly after placing the impression coatings, and you can go on with work without additional waiting time directly. This is an explantation case which was referred to our clinic. There's up to now only one literature regarding laser explantation of failing dental implants, and what we did now is 67 implants which we removed, and in 65 cases we were able to place an implant directly in the first setting. After removing the old implant, the damaged implant, we could place a new implant. Only in 2 cases, because of a very, very large cavity margin, it was not possible to place the implant properly. We had no primary stability, but in all the other 65 cases up to now it was possible. That will be published soon. So I'm not talking about the results. I'm showing one case. Otherwise, I can't publish it anymore. 56-year-old female patient, non-smoking, and so on, received 2 implants and sinus elevation 12 years ago, and now she had screw loosening and refixation during the past years, and we found on the X-ray a shoulder fracture. Here on the picture you can see very nicely that was a cylindric implant, and now you have enlargement here in the neck area, and in this implant the same. Later on you could see that it was a problem. A bit magnified. So this is the, we removed, of course, it was removed already, and healing screws inside, and the plan was simultaneous explantation and implantation of new implants by using the RWTH STG laser, which we offer to the patient, and that's why she was referred to our clinic, because this is a very gentle procedure. This is after removing the healing screw with, of course, anesthesia. We made a flap. Here you can see already the cracks in the neck of the implant, in the wall. Therefore, there was no stability anymore. And this is the tricky case, because we are talking about 11.5 millimeter implants, and you see, because of this defect, maybe 3 millimeters were exposed, but the rest was osseointegrated still. You can't screw them out like this. It's impossible. You would break the bone or anything like this. So with laser, we did it very nicely, very gently. These are the settings. If anybody wants to record this, it's not a secret. And so you see, now we are going with step down technique, not like in endo. Step down regarding the diameter of the tip. We're starting with 8 millimeter, then we're going to 6 millimeter, and then we're going to 4 millimeter, because the threads of the implants are disturbing. If you go with 1 diameter down, then after a while it's stucking, it's not going forward. And if you then take a smaller diameter, then you can continue with going into the depth. So this is one of the technical things we found out after a while. Creating osseous access around the implant with these settings. This is now with the NZ5, and the final tip was the NZ4. Of course, you have to go down with the settings, because the tips are not suitable for any energy which you're passing through. And this was the implant. You see, there's no big bone loss like you would have with any trephine burr, which is going cylindrically inside. We followed the form of the implant, which is a little bit root-shaped, and could take it out with. And you see the forceps. This is nothing for extracting an implant. This is only to remove it after loosening. And here you can see the lasered surface, and you see it's nicely rough. And you see the cancellous bone. It's healthy. There was a research done that after scanning, when you do the rotating implant bed formation with burr, and after this you go inside the cavity and scan the wall and remove the debris from the burr, you have up to 20% more implant bone contact later on, after healing. So the implant, especially in the upper jaw, the upper jaw is always tricky, and in the lateral area even more, very soft bone, and if you then can raise the implant bone contact surface around 20%, this is a big gain. Yeah? It's 1/5 more bone implant contact than without. Only by cleaning the cavity after using the burr. So even if you still use the burr for your implant bed preparation, after final step before placing the implant, scan the wall and wait a short moment for bleeding, so that it looks like this one, and then you can place your. That is removing the second implant. The last turn. These are the 2 cavities, and you see the bone loss in the tooth number 7 area was a bit bigger, so we had to take this in consideration. There was internal sinus lift procedure was necessary at the area of tooth number 6, and now the implants were inserted. Before it was 375, and now here we could place a 4.5 millimeter in the area of tooth number 6. Both implants had a final torque of 35 Newton centimeter, perfect. And in the area number 7, we placed a 5.5 millimeter tapered implant because of the slightly bigger margin and enlargement. But again, you see, it looks as if they fit in there, and as if they belong in there. If you do extraction and immediate implantation, the gap between the alveolar wall and the implant is sometimes much bigger than here. And this is because the laser is removing such a small amount of bone around the implant only, and still you will be able to lose it and take it out. This is placed in the healing screw and the sutures. And we have digital X-ray in our clinic. I told you the patient was referred from another clinic, and I was able to get, after 2 months, to get an X-ray at least of the situation of the healing. And you see the augmentation process here around the implant. Everything is nice. Now they are already prosthetically rehabilitated. This is from 2013, so long time already with implants again, and happy. This is what you can do with laser and you can't do without. No way. Yeah? No time delay after extraction. Normally when you extract the implant, you have to wait for at least 3 to 4 months for bone regeneration. Then you have to make a re-entry. You have to place the implant. After this again, you have to wait for the healing period of the implant. So in the end, it might be something like 8 to 12 months after removing the implant. And in this case, after 4 months, already rehabilitated. No swelling, a time-saving procedure, and of course, because of the laser, we have in the surrounding the biostimulative effect for better healing and a higher amount of bone implant contact later on. So these are some final pictures from our course program. I don't know if you know this guy here, Miguel, from Portugal. You saw before already, he's one of our teachers. He was young and crispy at this time, as me talking about anything. And here you see Dimitris, Dr. Strakas, young and crispy as well. And another picture from our friends. This is Peter Falstedt. He was responsible for the course program in Sweden and in Norway. And this is Leon. Who knows Leon? Wow. With beard and with a lot of hair. Wow. Still. So I wanted to give you some ideas so that you see that we were young at any time. Thank you for your attention, and I hope to see you in Cairo next year, October, the highest level scientific conference. And I hope to see all of you in Cairo. And a fantastic venue, I can tell you. I saw the place already. It's an old palace like we saw yesterday in the movie. Really outstanding, very nice. Okay, are there any questions?
Can you talk about the two-steps protocol with the more than 4 millimeters bone loss in periimplantitis? Which is your timing for the second procedure?
Due to the fact that it's more or less a soft tissue healing process we are waiting for.
Yeah.
It's not that long, something like 4 to 6 weeks. And when we see that the situation is stable, there's no inflammative process anymore, and if you did a good cleaning job, then in 99% of the cases it will be quiet after this. And then you can start with the re-entry. Because when you wait longer, you know there is no attachment on the implant surface from soft tissue, and the risk of re-inflammation is very high, and reduction of the soft tissue is very high. So
then we need a bigger flap.
Yeah, around you can say around 1 month is what we found out is ideal. Then the healing process took place properly, and after this, of course, in most of the cases you have to raise a flap, you have to mobilize the soft tissue to close it properly. But this is nothing special. We are doing in other cases without having periimplantitis as well, and it's working if you know how it's working. Yeah, but this is the timetable. But only in these cases. If it's less than 4 millimeter, and the second very important aspect is a good reachability from all sides. Yeah, this is very important. Yesterday, our colleague Koducha, is she here? I don't see. In the back. She showed a case where there was a vestibular entry. That was a little bit painful for me. Yeah, because it was definitely more than 4 millimeter. In this case, definitely under all circumstances, I would remove the crown on top. I would enlarge the incision to the neighbor teeth. Yeah, The step technique to preserve the papilla is perfect, what you saw from our colleague from Israel. But then you need access from all sides to this implant for a proper cleaning process. So you have to make a flap on the lingual and on the buccal side. Otherwise, you will not be able to make a 100% cleaning. And then the healing screw is placed. In this case, even that it was more than 4 millimeter because of the 3-wall bony defect, you have a good chance to do the regeneration immediately because it was a quite stable process. But I wouldn't do this thing without removing the superstructure, to be on the safe side, that's all. Not because the patients like it or I think it brings more money, but I want to be on the safe side regarding this. Yes?
Thank you very much for an amazing lecture. I think by far you are the authority in laser, and we respect that a lot.
No, you saw the authority.
You gave a lot of insights. So, in your opinion, if you had all the money in the world, all the researchers and the physicists, everything at your disposal, what do you think the next level of laser would be? What would you like to see in the next generation of laser machines? Because I see that there is some sort of evolution here from the past. And you are the best one to answer that question.
I don't know. Yeah, there will be. I know some research projects which are right now running, and it's really going in an interesting direction. So if you think now with these machines we are at the end of the development, by far not. The future will bring new things like what I showed for hard tissue preparation. But as well the small lecture before about the 3D techniques with printer and scanning and CAD/CAM systems. This is something, and laser we have to bring together. My vision is that in the future we have on the one hand a laser like the ultra short pulse laser, and this laser is guided by the computer. You just have to place the laser head in the proper position on top of the tooth. And then on the computer screen you are creating the cavity which you prepare, because on the X-ray you can see the caries, the decay inside, and the pulp, and you see the outline of the cavity which you need, and everything is designed on the computer, and then the same data file is sent to the laser, and the laser is doing the cavity, and in the same moment the CAD/CAM system, or the printer in the future maybe, will create a filling which afterwards can place directly inside. And then you will have a preciseness and a treatment speed and quality which is unbeatable, and which we don't have now.
I was thinking just that.
Yeah.
If you just put the head of the laser somewhere,
Yes.
and based on the CBCT data,
Yeah.
it knows exactly how deep to drill, how much to drill.
Intraoral scan, CBCT, laser, and the CAD/CAM procedures. We have to bring together, and then this is a step forward. What my colleague, he's a physicist, as I mentioned already, so he's not a dentist, and he's seeing these things from a slightly more objective distance than we dentists maybe do. He's always saying that the most tricky thing in the whole chain of treatment with lasers on the patient is the hand of the operator. Not the machine, not the settings, not the patient, but what you are doing with your hand is the most tricky thing. And the influence of this action, how you use the laser, how you move it, the speed, the distance, the preciseness, is much more important than 0.5 watt more or less on the machine. And what Yusuf told as well, if something is going wrong, it's not because of the machine, it's because of the operator. So in this case, and that's why I like this idea, you're taking a certain amount of influence out of the hand of the operator and give it to the system to have a better reproducible result. This is the idea behind it. It's not that I think that nobody is able to make a good cavity and make a filling inside and have a good result. But the reproducible good results or perfect results we will get if we have a chance to introduce any more kind of machine and interaction of this thing. And this is very interesting. And that's why I really like the idea of Rado, that his company is not only focusing on lasers, it's one tool, but he's focusing on, and the topic of our event here is modern future of dentistry, not laser dentistry, because it will come together anyhow. And this is even more important. And your idea to bring these things together and to give this to the doctors is very nice. I love it. Like I love to be here. Thank you for your attention.
Thank you.